Here we go.
Got it.
Welcome everyone to today's live show. I am super excited about this one. I feel very privileged. I was just telling Dr. Robyn, because today we are going to be discussing the medicalisation of labour, pregnancy and birthing women around the world. And we are focusing on a 4-part series of Dr. Robyn's very, very clever presentation on the isation syndrome. So Dr. Robyn, thank you so much once again for your time and sharing this with us today. Would you like to give a little introduction on what the isation syndrome is?
Sure. Thanks very much, Chelsea. It's late afternoon.
Just me?
Late afternoon, babe.
Go ahead.
You know, sometimes the brain doesn't. So if you see me looking, I'm looking at my screen for what we're covering today, because I know it's the 4-part series.
Absolutely. Yeah, go ahead. Read your notes. We won't judge.
No. I would just refer to it every now and then in case the brain does forget something. But the isation syndrome came about because my brain is a why brain. I need to know why. And what was happening is so many women were telling their stories, and still are to this very moment, on women's groups, in my video section when I'm talking with a woman, they're telling their stories. And for a midwife that's been around 50 years in midwifery, those stories are really scary. Some of them are just horrific. So I had to do something about the why. And so to relieve the pressure in my head, so it fitted with most of the words I was thinking about were like a syndrome with isation on it. So you'll see as we go along how that came about. And of course, I did end up doing a PowerPoint presentation too, and have had lots of good feedback from it. So it's helping us all, not just any one professional group, it's helping us all to try and understand why we go about our business the way we do.
Yeah, and actually it's such a huge topic at the moment. It might be considered controversial, I imagine, Dr. Robyn, which is quite similar for a few other topics that we've covered on these sessions. But that's another reason why I think it's so important. And like I said, we are having this is a 4-part series. If you look at the post copy above, you will see how that's broken down. And today's session is going to be focused on the medicalisation of pregnant women. So pregnancy, labour and birth. I am 36 weeks roughly, and I have firsthand experienced that. Dr. Robyn and I were speaking about this previously before going live, and it is a minefield out there. And I'm very, very fortunate that I have access to such wonderful education, the Thompson Method team, and the support that comes with it. So I have been able to navigate, which is a shame we're having to use those words, but I've been able to navigate. So Dr. Robyn, I want to start with just, I guess, clarifying what my understanding is of medicalisation. I think it's the rush, the process and other things, the rush in, through and out for us as pregnant women of the hospital system. Is that what you would agree with?
Absolutely, yes, it is. But let me start with, I don't mean to be controversial, I mean to be honest. And so sometimes when you are honest, it does become controversial, because it's understandable, because not everybody agrees. We don't all agree. But my practice is based on that every woman and her baby is unique, genetically unique, biophysiologically unique, anatomically unique, neurologically, psychologically, and emotionally unique. So if we take care of each woman as a unique person with her unique baby, then we're not creating a graph or a picture that everybody has to be the same. So maybe that's where the controversy comes in. So, but I really don't honestly mean to be like that. I mean to share my wisdom before I die.
And I honestly, I can't believe that we have to say this, but I think that it shouldn't matter whether something is controversial or not, if it's honest, like you say, yeah. And also if it's necessary. It is absolutely necessary for us to bring awareness around this subject. I found how many women really do not expect or even understand how the hospital system is going to work for them, like you say, in their unique circumstances. The amount of charts and graphs and Measurements that are definitely not unique to myself and my baby, that I've had to battle with this pregnancy is crazy. And I only had Jacob 2.5 years ago. And that really does show you how much of the policies and procedures that were probably brought in during the pandemic has really changed things. So that's something I'd like to refer back to later. But I think, sorry, go on, I'm rushing in.
No, well, in relation to, I haven't forgotten what the first question was, is that, which is good. But this will come more
enough credit.
It'll come more into the institutionalization of the rush through. But yes, definitely, since politicalization has been involved and then made all women go into big illness hospitals to have babies, then medicalisation of pregnant women, of their labour, of their birth. Nothing much about breastfeeding, very little. And, you know, there's very little after that moment of birth, providing the woman's a healthy woman, you know, and there's no major complications. So medicalisation has changed the process that women go through once they hit the system. And, you know, even in private institutions, you know, it's really not, the focus is not on that particular woman all of the time, according to the stories that they write, they tell, and speak with me. So, and
actually, I found a few studies that actually imply that privatization of certain hospitals has increased the risk of intervention. It's actually increased C-section rates and other interventions that we know can negatively sometimes impact breastfeeding journeys. So I think before we get into the labour and birth, which of course we know is huge, we understand, and I understand, thanks to you, that pregnancy is a natural transition into that, and the decisions made during pregnancy really can impact everything that follows on after that. And I think
medicalisation comes into all of that, is what I'm trying to say. So
absolutely.
What the question is medicalisation really necessary for healthy women?
Yes,
absolutely. I don't think so after my practice of 50 years. I don't think so. I think, you know, that could be reverted back to where women are in control, where women have the say, where the medicalisation of their bodies and the coercion of their minds is changed.
Yeah, that is the question that we all need to ask. I think it's a very important question. Is medicalisation?
So listen to her, sit with her, listen to her.
Throw the policies.
She will, yes, policies are not law. She will always know, if you listen, her instinctive knowledge and her knowledge of self is there, and we must give credit for that. And it does take time and patience on behalf of the professionals, medicalisation professionals, medical professionals too, because you have to sit and listen.
Yeah,
and, you know, if you sit and listen and you observe quietly, then you have much more information coming your way. And you can work within that trajectory with that woman according to her needs, not necessarily the medicalised needs.
Yes, and that's a perfect track straight into what I was going to say next, which is about consent. You said it was very important that we discuss consent amongst this topic, because it's something that many women are reporting, and research is showing that women aren't feeling they are being given full consent. They might at the time feel as though they've been rushed into giving consent, and some people are almost bending and jumping through loops for this consent, but actually it's coercion, and we were talking about this also before. What would you say on how it makes you feel to see and hear about the things that are happening right now?
Well, I feel it's wrong when women are not provided consent, that they're coerced by fear. But even signing a document 6 weeks before is not consent, because we don't know what 6 weeks before what the consent might need to be. We don't do that. So the law of consent in Australia, and I think in most Western countries, is pretty clear that you have to provide the benefits, the risks, the alternatives. You have to talk about their rights, their right to say no, their right to accept, or their right to seek another opinion. Our duty of care states clearly that we must obtain consent. Hence my video on keep your fingers out of my vagina, please. Because consent was not being obtained. It was just they had to do it. It was a procedure. It's about knowing what you're up to, but you're not spending time with the woman to know where she is, to hear what she's doing, to see what her body movement. And when you do that, the midwife generally does that, the experienced midwife anyway, generally does that really well. So it's a very sensitive way of understanding women and what their particular needs are. The woman who's experienced sexual abuse from a child, we don't even think about that, nor do we talk about it. In the videos that I have, women do talk about it with me. But, you know, it is a difficult time in history for women who are trying to give birth to their babies.
Yeah, and I think that lack of or sense of control is being taken from us. And like I said earlier, it's almost been a battle for me to keep my birth and pregnancy preferences on the straight and narrow. And I don't really feel like it's right that I have to debate that. And I'm in the UK. I feel like we are very fortunate to have some of the best rights for women in the world, but I feel like this is an area that is just people are turning a blind eye to. So I've actually got a little quote here that I think you'll be very interested in hearing. This is from birthrights.org.uk. So this is an organisation that helps educate women on their birthrights. So if you are from the UK, or even if you're not, it still cites many facts from around the world. So do go check it out. So in August 2021, the Patient Information Forum conducted an online survey, and they wanted to hear about women's experiences of being induced in collaboration with charities that are run by birthrights.co.uk. So this is what they said. They said the survey confirms that we hear on the advice line that the quality of conversations around induction is just not good enough. And women and birthing people often feel that they have no choice, or they don't understand the choice that they're making fully. So that really does highlight everything you've just said, Dr. Robyn, and the stories that you're being told. And it breaks my heart to read that out.
Yes, because they're not being explained the benefits, they're not being explained the risks. Now, certainly, with healthy women, they do not need to be treated that way. But if a medical person is involved because the woman's not well, that's a totally different story. And that's where we have complementary services between the woman with us, with the midwife, and the medical person involved. It's a complementation of what we do together that provides the service for the woman. It's not one being better than the other, because we all have skills that are required at some time in the care of women and babies. You know, it's very important to understand that. It's healthy women that we talk mostly about that do very well. And I think a lot of that's to do with the fact that they have a lot of, not a lot, that's the wrong word. Stop that, Robyn. Many women are aiming to go back to having their own midwife, their choice, their midwife of choice, a midwife who is with woman, as Caroline Flint from the UK told us many years ago. She is with woman. And one of the midwives I read often about in the UK is Deborah Niger, and she's with woman. And I just think that's where we need to take. And when we think about the First Nations people here, they are with women, and they do an amazing job together as women. And this is what's happening, is we're falling apart because of the fear when maternal decision making is interrupted, is overtaken. And why would you rupture membranes when they don't need to be ruptured? Just because it hastens things, and it then ends up in a cascade of intervention. Because,
yes, and Sarah Wickham shares some really great research and stats on induction in general, not just the breaking of membranes we've discussed before, and there's a blog on that on our website. We've also got the sweep that many people don't understand is a form of induction, and she really does explain it with all that doctor jargon, and it is very easy to understand. And
she is so clever, Sarah Wickham, and she writes perfectly from my point of view, and we can all understand what she writes, and she researches thoroughly. So there's a very intelligent, experienced midwife who's doing a favour to all of us across the world, really, with all her, and I have her books. One's on my bed, 6 of them are over here, and
I think you mentioned you got In Your Own Time, which is one of her books, right? Which is specifically about induction.
I've got all but the latest review of one. I've got all of them.
Yeah, it's a fantastic resource. So please do check that out. There's lots of free resources on her website as well. And of course, as Robyn said, there's the books too. So Dr. Robyn just touched upon the term with women in reference to midwife. Now, I didn't actually know. I thought this was a Robynism.
It's with woman.
With women. I do apologise. I'm so sorry. I always manage to get it right.
Caroline Flint.
I've been looking into it and I learned that midwife actually means with woman. So it does make sense. Everything you say, of course, does make sense. But in reference to their role, it's really important that we remember that as we continue the discussion. And also, you talk often about the multi-agency of professionals following on from the midwife. In the UK, generally, low-risk pregnancies are dealt with in the community by a midwife. Some appointments are done by the hospital or consultants as well. But I think it's interesting that you say that our focus is on healthy pregnancies and healthy women that don't have risks. However, we're hearing every day that those that fall into that category are somehow slipping into high risk without actually understanding what those risks are, why they are, and many don't agree that they are risky. For example, measurements, big babies, reaching your due date because of policies and procedures. So
gestational maturity comes down the family line. And, you know, I've had women that have gone out to 43 weeks, but on the average, it was 41.5 weeks for women who had no intervention and were able to achieve their baby's gestational age that was mature for them and their uniqueness and their genetic history.
And actually, when you look into the risks, we will get into this in the following weeks when we talk about things that are further into the intervention side of things. But when you look at the risks of due dates, another amazing source by Sarah Wickham, the research is very outdated and not really supported or evidence-based anymore. So we encourage you to, of course, do your own research anyway. But let's touch upon those policies and procedures following on from consent and coercion. They're not law, are they, Dr. Robyn? We don't have to agree just because they say it's their policy.
Yeah, policy's been written by some for the institution's benefit, not for the woman's benefit. And the policies, then everybody feels, because we'll talk about that too, insurance, they feel they have to follow everything that's written for them instead of increasing and improving their own skills and knowledge. And by following policies, sometimes we create more problems for the woman because that's not what she's wanting and we're not listening to her. So policies are not law. The woman has the right to say no to policies and procedures that she is not willing to have. And again, if you sat with her and talked with her, you may be able to obtain consent, but certainly not by fear.
Yeah. And I think that in the UK here, there is a huge movement going on with our very wonderful midwives who feel as though they themselves have been medicalised. They feel attacked because of the increased interventions. And it is just a very sad situation, I'm sure, which is happening all across the world in the Western hospitals, as Dr. Robyn mentioned. But the interesting thing that you spoke about, in the UK, we have a national health service. So a lot of our services are publicly funded. But of course, in other areas around the world, in Australia and the USA, a lot of that is insurance-based, privately funded. So I know that you do love Transforming Maternity Care Collaborative, the very special blog. I know that I love that one. And there's new research from New South Wales and Australia, and they say that private obstetric care is associated with higher intervention and cesarean rates, which of course you know.
Rocketing sky.
It's very. I didn't actually know how high the rates were, but it says while cesarean section can be life-saving, we know that, for the mother and the newborn, current levels have reached epidemic proportions, which needs urgent strategic action. So that is definitely something we need to need to understand, I think.
It's the questionable interventions that we need to consider and stop and think, and not just apply an intervention because, you know, it's been your practice or that's what you do or that's what the expectation of the policy is.
Yes.
Again, it goes back to that unique woman, her unique body, her unique baby, her unique self, her genetic background, her family history. A family history is so important. And if you saw that, I just wish, I'm hoping to do some more research with my magic professors one day soon, and the team that helped me with my previous papers, like worked with me through my previous papers from my research, because we need to consider many more things now that I have a huge database that needs to be looked at. That's the problem. It needs to be carefully looked at, analysed properly by experts, and you know, so there's a whole lot of work to be done. I'm just wanting to do that badly.
You're always finding more work to do on you. But this is why it's such a special movement, because you want to keep improving things and highlighting things and moving forward. And
well, you need to have funding to do it, otherwise people can't survive. You know, they can't just, you know, do all that work and not have respect for what their skills are. So I do want the team that are going to be involved with more research on you know, much more data now to be paid for their wealth of knowledge and their experience. You know, it's so proper to do those things in the best possible way. So we're working on that at the moment. My Joanne's doing that.
That's exciting, isn't it? Getting the girls on the research side of things. I think it's very special, the evidence-based methods and research we have.
So let's just tie up on medicalisation a little bit. Have I covered it enough, do you think?
Yeah, I mean, I would really like to move on to, we've done a lot on pregnancy and we've covered parts of labour, including induction. But let's talk about how that impacts the birthing and new mother. Let's talk about how it impacts that.
Read out my short notes here. Would that help?
Of course, if you want to. I was going to talk about the delay and interruption of the first breastfeed, which of course.
Can I just go back a little bit further, where medicalisation takes control over women, their bodies, increased administration of opioids. That is one of the major factors that we are seeing with the sleepy baby syndrome, and added other things, but we'll talk about those later, and the babies being jaundiced. We're actually seeing that. We're recording that information. And affecting the mother and her breastfeeding. We've done all the coercion and decision-making that women should be making with consent. There's a lot of disregard for a woman's self-knowledge. No, that can't be right. You know, you wouldn't really know. And maternal instinct, which I do like to make sure I'm listening to that woman, and she'll always give me an answer to what she's thinking and what she knows. I listen carefully. In my Q&A sessions, if I read the last sentence first, there it is. There's the answer.
We do doubt ourselves often, don't we?
So, and that does then interfere with breastfeeding. The first breastfeeding, the first 3 golden hours that I talk about, and the first 72 to 96 hours until the milk volume peaks. And people think that milk should be there straight away. So many people think that, but it takes the baby a lot of work to feed frequently over that time, to release the hormones, to increase the milk volume gradually, and then it peaks on the average about 72 hours.
And I think the problem is with medicalisation, it's interfering with that. There's a delay, there's an interruption with that special time between the mother and her baby. And one of your main points of your presentation, the Isation syndrome, is lactationization, and that is something we can go really into detail with, how it impacts the breastfeeding mother, the breastfeeding person. So we will go into that a lot more in detail in a few weeks, because I think that like, as Dr. Robyn just said, people, they lack the knowledge of how the decisions they're making during pregnancy and labour can impact that very special time post-birth. So that is an important one we should remember.
And look, if we interfere with the breastfeeding in that first 72 to 96 hours, in my research, it showed that women were having breast engorgement.
Yeah.
And then mastitis. So nipple trauma and those two things were high in the statistical information. So again, we have to step back and say, is this right for this woman? Let's ask her, see what she thinks. Let's have a look at her baby. Let's have a look at how her baby's output is changing. You know, we've known for years that the colour, the consistency and the volume of baby's poos changes when the milk is and the binding process is working if they've had medications and drugs. We know what to look for in the output. And that's not the only thing. Of course, if we were concerned about a baby, we don't want a baby to be totally jaundiced so that we run the high risk then of kernicterus, or, you know, we don't want that to happen. So we're watching very carefully. But on the average, most women don't have that problem. So
there's a lot of fear and coercion that is able to be placed upon a family because of the lack of education around breastfeeding. And if you're pregnant and you're wanting to breastfeed and you're listening to us talk about these things and you're thinking, oh, I don't know about the colour of baby's poo, or I didn't know about the first 72 to 96 hours, then just get in touch with us. Dr. Robyn's online education is, sorry, Robyn, it's incredible.
I'm busting at the seams. Understanding APGAR score is so important.
Exactly, all these things. The three
not cutting the cord until the cord has stopped its blood flow. Yes. You know, all of those things are so important, and we tend to ignore it in the way the women are telling me the stories.
And I think that the main reason for this is because of the hospital's policies and procedures getting involved with that, the boxes that need to be checked. So if you do want to know more about the online education, which everything we're covering over this series is covered in so much more detail, you would be able to really get off to the best start and be confident. And there's prenatal sessions included as well for those who want to explore Dr. Robyn's brain during pregnancy, which has been amazing for me this time. And ladies and gentlemen, there is a 50% flash sale on currently. So take advantage of that. The boss doesn't like to get involved in all of that, but there is a sale on. So it's very accessible, usually, and even more so at the moment. So take advantage of that and get in touch with our wonderful team. We love connecting with women like ourselves. So I think the 3 golden hours for me is where things started to change with breastfeeding and things started to go downhill. And I think that a lot of women who are impacted by the interventions, the cascade of interventions, like you say, unknowingly, are also quite negatively impacted without being able to make an informed decision. And I just wanted to throw this at you, Robyn. You'll love that this study has come out.
I'll use my Morrow reflex if you're going to throw it.
I sound like such a Brit sometimes, don't I? So this is the Lancet report. It's a very famous report right now. Dr. Sarah Wickham and a lot of other name drops that we've used in today's sessions are reporting on this. It's a fantastic research piece. It's called The Maternal Outcomes of Birth Interventions Among Women who Begin Labour Intending to Give Birth at Home, compared to a woman of low obstetrical risk intending to give birth at hospital. So it is a home birth versus hospital kind of debate that's going on right now in the UK, worldwide, definitely, yes, it's one that's necessary. But it says among low risk women, as you said already, Dr. Women, those intending to birth at home, which means they don't necessarily have to end up birthing at home, but the ones that intend to and plan to experienced way fewer birth interventions, untoward and maternal outcomes as well. So that is something that we need to, and this was done on 16 studies provided from 500,000 intended home births. So that's a very...
Way back when I was home birthing, I rarely did vaginal examinations.
Yes, well, I mean, even if you're in the hospital system, it's not necessary. You say in your video, keep your fingers out of my vagina, that there are other ways to observe. So thank you for sharing that with us.
That's all right. We've got a lot more to cover over time, haven't we?
We have. I'm so excited. I mean, there is so much more to cover. We will never have the time in these sessions to cover it all, will we? But I just think it's important to highlight and share and make aware with love as much as we can. So what do you think about what we've spoken about today? Are you pregnant? Are you experiencing any of the things? Perhaps you've had a very positive experience, or perhaps you haven't. Let us know, get in touch. What do you think about what we've discussed? What do you think about medicalisation? How do you feel about Robyn going out there and getting some new research for us? I know that got me excited. So yes, Robyn, is there anything else you'd like to add for women watching?
I think we're on track as far as starting. And don't get me wrong, I have some really wonderful medical colleagues right through my career, but there's definitely a change in medicalisation in the practice of what is happening with women and their bodies in comparison to how midwives work with women. So there's definitely that happening, no doubt. And sometimes, you know, when I'm crying with a woman online, it's very sad, because when you leave her from the hospital, you have no idea how she's feeling at home, what she's going through. And with early discharge and just being put out there, it's very stressful. So, you know, and the women are telling these stories while I'm online with them, and while my team are online with them as well.
Yeah, and it is quite distressful, like you say, and especially when they've been coerced into a decision they have no control over or understanding of. It's very heartbreaking, and as we know, it's not really lawfully done in a sneaky way.
Flat on their backs to labour, and that should never happen.
Absolutely. So yes, let us know. We do sometimes find it difficult to talk about this, especially with stories so personal to women, but sometimes it can help if you share yours. Thank you so much for watching. We will be back with an update on a date and time for part 2 of this very special series, and we are very excited to be talking about it further. Dr. Robyn, again, thank you so much for your time, and we'll see you ladies soon.
Okay, you take care and have a wonderful day.
Bye, guys.
See you. Bye-bye.